CFR, the Center for AIDS Research here at Hopkins. We've had a couple of different seminars over the year, and this is a sort of follow-up to one we had a couple of months ago, talking specifically about men who have sex with men and their access to clinical care. We have with us Renata Arrington-Sanders. She is a physician in adolescent health here at Hopkins. She came to us via the University of Virginia and the University of Cincinnati, where she did her residency in medicine and pediatrics, which seems sort of required if you're going to do adolescent medicine. She is working here over in the clinic and focusing in on adolescent STDs and HIV infection, and has a lot of interest in engagement in the community and with the idea of improving access to prevention and care for younger men who have sex with men. So I'm going to hand this over to Renata. I first just want to thank Kate Boehner for making it possible for us to have pizza and drinks here today. And with that, I will please help me welcome Renata Arrington-Sanders.
All right. Well, thank you for coming. I really appreciate your interest in this topic because it's a very a love of mine, and this is what I focus on all the time. And so I'm glad that I'm not the only one. I'm not alone. So today, hopefully I'll get through what I want to talk about in 30 minutes, and if we spill over, maybe Holly, that'll be okay with Holly. But I wanted to try to just talk a little bit about sort of the need for research in this particular area, particularly sexual minority adolescents. So my work particularly focuses in African American, gay and bisexual men and other men who have sex with men. But that does not include all sexual minority adolescents. That does not include lesbian women. It does not include questioning youth. It does not include it may include some questioning youth. It does not include transgender youth as well. So the purview is much greater than what I'll talk about, but this is just one sort of view of looking into working with vulnerable youth and really understand some of the complex ethical issues around working with research with adolescents. And discuss some strategies that I've used, and hopefully we can have an open discussion at that time. Maybe other people want to share other strategies that they've used when approaching IRBs and ethics around working with adolescents. I actually start to think about things from a clinical perspective. As Holly shared, I'm a physician by training, internal medicine, pediatrics, adolescent medicine, HIV specialist, all in one bag. So I wear a bunch of different hats. So, I start at the bedside, and, we talk a lot about translational research, and maybe this is a, reverse translational research, because I start with what interests me most and what my patients talk about. And so this is a patient of mine. So this is a 17-year-old male. He presented for routine care, and on his sort of evaluation and informal interview and discussion during his exam, he identifies himself as gay or homosexual. He says that he's worried about HIV and HIV risk. And he says he's never been tested for HIV before, but he's had 4 prior penetrative partners. And he only now feels comfortable talking about his sexuality. And when I ask him about who he's having sex with and to talk about his relationships and how he defines them, whether or not they're healthy, he says that none of them are healthy. So I was sort of struck with, well, how do I help this young man navigate the roadmap of life? He's 17, and he may have 80 more years to live, right? Or more, he may live past 100. And so how do I help him navigate that roadmap as his provider, hopefully as his friend, as his mentor, whatever. And so starting with sexual development, if you look at which youth actually engage in same-sex sexual activity, and we like large national data sets, so starting there, we see that it's fairly actually normative. And on the left hand of this, I guess this is more of a red and blue on your slide. It's more of a pink and blue on mine. But what you see here is that for females, as much as 10 to 12% of females have had any same-sex activity with another female, whether they're 15 to 17 or 18 to 19. And for males, yeah, almost 6%. And this is the National Survey of Family Growth, looking at this sort of longitudinally, or looking at it over two comprehensive data sets. In the Growing Up Today study, you see that there's actually a larger percentage of youth that describe themselves as either mostly heterosexual, bisexual, gay or lesbian, or not sure. So if you sort of extend, if your mindset is open to, and what I believe that there's really an overlapping sexual development that occurs, and that sexual orientation may not actually match sexual behavior, and may not match who you're having sex with at that time, and it may be fluid and overlapping and changing throughout life, not only in adolescence but throughout life, then you see that really for females could sort of this larger group of 13, maybe 14% of youth identifying in that or falling into that group, and as much as 8% for males. Bruce looked at, in a sample of 200 self-identified gay, bisexual, and questioning males, and found that sex with a female was actually concurrent or right before first penetrative sex with a male, and that a little over 30% of those in that population had described having their first experience with the female right around the same time as their first experience with the male. But we really don't know how those experiences impact one another. We don't know whether or not the first experience really impacts that first experience with a male. And so why study, or why look at this particular population? Why focus more in sexual minority youth or LGBTQ youth? Well, I could talk for probably an hour about the challenges that youth experience. We know that these youth are more likely to have attempted suicide, more likely to report depression, more likely to use polysubstances in the last 30 days. And we also know that young, as the Centers for Disease Control and Prevention look at rates among young men who have sex with men, are more likely to have an STD diagnosis and an undiagnosed HIV than any other age group. And this is particularly prudent for 13 to 24-year-olds. And what this slide shows is that while in the other age groups, we've seen somewhat of a leveling off in some of the groups, but in the younger age groups, we've really seen from 2008 to 2011 an increase in risk and in HIV infection in men who have sex with men. In Baltimore, the rates are not any different. So we, as part of getting prepared for something called Connect to Protect, which I'll talk about in a few minutes, when we looked at this between 2005 and 2009, this data is from the Center for HIV Surveillance and Epidemiology, and I know IDEHA has changed its name, and I haven't changed that on this slide, but we found that there were 533 new cases that were reported in this age group, 13 to 24. These were predominantly African American, predominantly males, and predominantly occurred among men who reported having same-sex activity with other men. And when we looked to see where these men were located or diagnosed in Baltimore in 2011, where they were tested, we found a similar butterfly distribution that a lot of people show that's associated with chlamydia, gonorrhea, violence, high pregnancy rates, and the risk, sort of the factors go on. And those areas that were in the 217, the Sandtown area, the 01, which is the Pratt and Franklin area, the 13, which is the Broadway East area, the 14, which is Morgan, and the 06, which is the Wilson Heights and Roseville area, were the highest areas that had the highest rates of positivity among youth who were tested. So how do we approach this? How do we, so I'm a provider, I start at the bedside. I have this young man, and he's had 4 partners. He's never been tested before. He's coming in, and he's getting comfortable with me and telling me about his sexual identity, his sexual behavior, and how do I approach this? And I think how I've thought about this is to first think about using an ecological framework. And I think a lot of us are familiar with Bronfenbrenner's ecological framework, and how this really sort of breaks down that it's not just sort of the personal or the individual, but also the social, the structural, and the policy level factors that could actually impact one's risk for HIV. And I've been focusing mostly on the individual and the structural areas. So I want to start with one of our projects that we work with and oversee, and some of our coalition members are actually here today, and that's Connect to Protect. And so Connect to Protect is a structural level intervention. It's actually in multiple cities across the country, and the goal is to actually create community mobilization that focuses on altering and creating structural elements in ways that will reduce HIV incidence and prevalence. And our target population is African American young men who are gay and bisexual, and other men who have sex with men. And so what it does, the purpose of a structural change is to actually try to shift the paradigm, to shift the practice in that particular area, and to try to maintain successful relationships between researchers and community members, as well as community agencies. And I really enjoy this because I get to work with good people in the community, and as well as trying to make a change from a research standpoint. And so these are 3 areas of focus that we've been working on as part of the coalition. The coalition is our community members that are on the ground. It's not researchers, so let me be clear. So the community members actually identified these 3 areas as the hot areas that they wanted to focus on: housing and safe spaces for youth, linkage to care, and mental health and substance abuse. And so if you look, and I know this may be a little bit busy, but if you look to, I guess you're right, my left, what you see in the box is how for each of those areas that the coalition has focused on, they've tried to create structural or community level changes around that particular area. So for example, trying to increase access for competency training, cultural competency training for the truancy office that actually will work with a lot of LGBT youth. So the goal is in that situation is to increase sensitivity and cultural competency in that office, so that when those youth actually are arrested or found truant or in that office, then they're treated more appropriately, they're engaged, and that could lead to fewer risk-taking behavior in the future, because they're actually it actually impacts their own persona of how they perceive themselves. Also, to try to create more GSAs in Baltimore, in the schools, in the clinics, in community centers, because there are some GSAs in Baltimore, but they're not very active. And so trying to create those GSAs so that they can actually provide a safe space for a lot of these youth in those areas. For the linkage to care community, really focusing on trying to link individuals to care, as well as to increase HIV testing in community as well as emergency department settings. So we've heard from some of the emergency departments in the area that a lot of them are not doing universal HIV testing. And there's some barriers around that. So this young man that I presented earlier, he had sex, he had 4 partners, but had never been tested. So really making the system level to increase that change in Baltimore. And then with regards to mental health and substance abuse, increasing acceptance for youth by actually using a PFLAG curriculum that has been used and studied, and actually trying to implement it in other areas that are where youth are accessing. So one example is we've had the opportunity to work a little bit with Connect to Protect and the health department with their balls. And so the health department has been working with the house community to create these annual balls where they also provide HIV testing. And what you can see in this slide is that the testing rates, especially in the last ball, have been very, very high. 15% positivity at the mini ball. With an estimated new positivity of 7%. So that's really high. So this is a high-risk group that we're serving to try to create these structural changes. I also wanted to highlight the linkage to care piece a little bit more, because we have the SMILE linkage to care program to try to actually link individuals to care that are newly diagnosed. And with this is to also identify structural barriers and systemic barriers to care. And so since December, when we've had this grant in place, we've successfully linked 18 youth, and 22 youth were identified, and 18 of those youth were successfully linked. So we've successfully linked 81% of those youth, and Anastasia's here, who is our linkage to care coordinator. And a lot of those youth have already started to be engaged, having actually seen a medical provider more than once. But I think what's really important about this is that with this program, it really helped to identify a lot of barriers to care. So, you know, a lot of the youth have lost their insurance, or maybe they have private insurance and they can't be seen at the health department, but they don't want their insurance to be actually billed for their HIV care because they haven't come out to their parents. A lot of youth have a difficult time navigating in the clinical spaces. There's a long waiting time sometimes. We found that that's a big barrier. You know, that the standard is you come in, you're seen, but the first medical appointment's not for a month or 2 weeks. And so a lot of those youth are struggling. They want to be seen immediately because they want to know what's going on and how do I deal with this. And so those are some identified barriers, and I already talked about the emergency room. So let me go back to the case. I also, some of my more recent work, and so I talked about the structural work that I've been doing in the community, but I also like to look at the individual factors and the personal factors. And so looking back at this gentleman that I was describing, 17-year-old, and he says none of his relationships are healthy. And I hear this a lot, and this is sad. It breaks my heart, it really does. So I go back and I'm like, let me look at the literature, see what's out there, figure out what I can find to give this youth so that he can have a healthy relationship. Nothing. There's nothing out there. There's really a paucity of information about how to help youth that are going through sexual development. I see some nods over here. You hear me, sister, right? So, you know, that are going through sexual development. And so I really focus on that emerging sexual identity and exploration. And I do a lot of this qualitatively. So one of the first projects that I did to look at this was to really look at reasons for first experience in a sample of 20 young men that were 16 to 24 years old. Now they were about 15, their mean age of first same-sex experience was about 15 and a half, almost 17. And they were recruited in Baltimore in clinics, from venues, and using a modified snowball sampling technique, and as well as postings on the internet. And what we found was that a lot of the youth described that their first experience was really a desire for them to find someone they could talk to confide in. They're you know, emerging, they're different, and they're just looking for someone who they can just sort of confide in their who they are, their sexual development, experience things with. And so a lot of these youth described having these homeboy relationships, that it was like their best friend or their boy that they would hang out with, and they'd go play PlayStation and Nintendo, and then suddenly, you know, he said he liked him, and then it's like, hey, you know, this is safe. and I could talk to someone. And so here's a representative quote. I think gay people, they tend to try to confide in someone. They can confide in all the time as much as they can because they don't get their feelings out. And that's what I was looking for, because he was actually my friend. So this young man was just looking for someone that was close, that could provide sort of that intimacy for him. But while these youth are emerging in their sexual development, there's a larger social environment that can sometimes be chaotic and can be difficult for the youth to understand, to articulate, and to interpret for themselves. This youth says, I can't fully explain it. It was just like I was going through a new process or something like that, and it was just like my life. Well, it wasn't. It was something about me that was changing, and I just didn't understand it. And I was going through like something like bad in my head, not like harmful and anything like that. It was just like something was just changing, and it was just changing so rapid. Now, this young man describes having had sex for the first time with a man later. So he was 18 around the age of his first sex, but he also describes this, feeling a lot of anguish and a lot of just mixed feelings. And I think there was some guilt in there around what was going on with him, and he was trying to cope with that and feeling isolated, not having anyone to talk to about it. A lot of the young men also described that they had older partners during these first few sexual experiences. And we know that older partners can potentially put these young men at risk for HIV because of these bridging partnerships with a higher HIV prevalence. Older partners have been associated with higher rates of HIV infection and lower condom use. But I did want to understand also what needs that these youth may identify or seek from older partnerships. Because I think that informs sort of the behavior much more than just looking at the risk. And what we found was that a lot of youth they were actually seeking older partners because older partners were more mature, less likely to play games. I mean, that's how they interpreted it. These young men that are my age, they're out here. I'm trying to not have risk, right? So, and I think in some respects, some youth are seeking those partnerships that they perceive as not risky, and they're using sort of their own inherent beliefs around what they perceive as risky or not, and they're seeking these partnerships that actually may end up putting them at risk. But they described that these older partners were stable, emotionally mature, and then also this key component of exposure and needing more exposure into the larger community. And I think that this is shifting because of the internet and the ability to get more information out of the internet. But a lot of youth described that this partnership was critical in their early sexual development. And so this young man really talks about how this older partner was helpful in getting him exposure into the clubs, but also helpful in helping him sort through whether he was a top or bottom, because those were his early experiences. And so, I think that we have to be very thoughtful when we look at older partners, and just in the context of risk, because older partners may provide a lot of these needs for youth, especially when they've been displaced. So, I go back to, well, what does this mean, and what does this mean? And I come to a conceptual framework that looks sort of like this. And I think that these early experiences are so important. My patient described not having any healthy relationships, and he had had 4 partners. These early experiences are so important because they may impact satisfaction earlier on, but may also impact sort of the trajectory that occurs afterwards and what happens next. And so I think we need to unpack that and understand that a little bit more. And so more recently, I've been looking at condom use and how that interrelates with intimacy and trust, and how the youth expect things in their relationships, and that's how they determine their condom use. And so when we looked at trust and intimacy, and tried to look at, whether or not youth were using condoms within those relationships, we found that a lot of youth described not wanting to use condoms throughout the relationship, but inherently trusting early people in the relationship. So yes, I have this 6-month time frame. I gotta know them for 6 months. But suddenly, the emotions get in there and it becomes more intimate to them. They feel like they've connected with the partner and they feel like that equates to trust for some of these youth. And so they describe in this sample that they were able to sort of not use condoms because they felt like that they had connected and could then trust that partner. For example, this person says, with my first relationship, I found us being like, we doing little things you do when you was a teenager. We were having sex because I was young. I didn't know. Like, okay, I knew about condoms, but I didn't know. We used condoms the first time, but I'm like, okay, you my baby. So something's changed. Now you my baby. You my lover. I don't need to use condoms. And I think we hear that a lot, so that those trust heuristics interplay a lot within relationships. But what about pleasure? What about satisfaction? I know we don't want to know about sex. No, people are not having sex and they're not thinking about sex is good. But hello, sex is supposed to be good, or else we wouldn't be doing it. So we looked at pleasure, and especially during the first experience, and whether or not it was pleasurable. And what we found was that a lot of the youth described being the receptive partner during the first experience. But they also described a lot of pain during the first experience that was mixed with feelings of very much excitation, of fear, of guilt, but of also pleasure. And that a lot of the youth who described pleasure described that their partner took their time, used lubrication, and sometimes condom use played into that. So that, I know we don't want to talk about youth having sex and whether or not it's pleasurable, but we have to unpack that because that's going to dictate whether or not a lot of these youth are actually using condoms, especially when it deals with pleasure and satisfaction. I also looked at how condoms themselves impact pleasure in a separate sample of 30 young men, and found that there were different factors. There were mediators of condoms and pleasure, and then there were moderators. And so that there was that, again, getting back to what we already heard, the emotional connectedness came out again. That actually mediated between pleasure and condom use. But there were also moderators of the event, lubrication, relationship of the partner, and then the specific act, whether you were the top or the bottom, impacted pleasure and modified the youth describing pleasure during sex. So I think that I've gone through this fairly quickly, and this is sort of a very wide brushstroke of what I've been doing, but I think it gives you different perspectives of how to address the question from a personal level and from a structural level, and how to maybe bridge from the bed into the field. But I think it also highlights that we need to do more. We got to look at pleasure and sex and early experiences and how they impact using condoms, and we have to not be afraid to talk about it. We've got to do more about that. So you say, well, you got through the IRB, how did you do it? Okay, so that's the second part of the talk, is really, so here I am. I had a study, and I wanted to study youth, 15 to 18 right now, 15 to 24 in the prior sample. And when I first submitted the IRB application, the IRB expressed a lot of concern about not getting parental consent. So how do I do it? Well, I don't know. Prayer, practice, I don't know. smile, encouragement. But I think the first step whenever you're doing research and work with adolescents is to understand the first principles of ethics and to apply those to adolescents. And so we know these, they're respect for persons, beneficence, and justice. But I think that with respect for persons, we have to balance that these youth are autonomous, but they're also, there are potential vulnerabilities that may exist with working with adolescents. So we always sort of think to doing research in incarcerated populations that you want to provide individuals the opportunity to do that research, but simultaneously you also don't want it to be coercive, and that youth would feel like they have to do the research, for example. But there's a lot of benefits to participating in research, individual benefits, benefits to the larger society, and I think also you can't exclude youth. Okay, so that more than anything, it would be an injustice to actually not look at youth and not to think about including youth into research. And you can think about, the example of my doll, the years of my doll research that was done in men, but it was for women. That doesn't work so well. That's injustice, right? So you have to be sure to actually include the population that you hope to engage and to make a difference in. I think the second step is to really balance between when do you need adolescent consent and when do you need parental consent. And to do that, you have to first understand capacity. And so capacity for informed consent by adolescents is really a developmental construct. So it develops over time, and it's very variable in adolescents depending on their age. But it's the ability to understand information, to appreciate the significance of the what they're doing, and then to weigh the risks and benefits. It also includes being able to volunteer and agree to be involved in that research. And so why capacity matters is because it matters with risk and the ability for youth to consent. So if you're doing low risk research, a survey, for example, then capacity theoretically should be assumed, right? Because it's low risk, and adolescents' informed consent could actually be substituted for parental permission in that case. But greater risk research, and then you either have to make sure that the youth is able to articulate the capacity, or it may merit doing something else to ensure that youth actually have the ability to understand that risk within that research. And so I think the sort of what defines low risk versus greater risk is where people struggle all the time. What's minimal risk, which is more than minimal risk. And so I think you can also, I'm going to get into minimal risk in a second, but you can justify parental consent in some areas. So where consent is unreasonable. So if you have work with youth where there's abuse or neglect and it's unreasonable to consent. But also when adolescents' rights to clinical care may be violated if you actually get parental consent. So a lot of us work in an environment where youth are seeking reproductive services, HIV testing, information about sexuality, sexual disease information. By getting parental consent, that actually may violate their ability to seek those services, and their care may be compromised. So in that situation, then you actually can get a waiver of parental consent because it's much easier to justify waiver of parental consent because they're already protected to seek those clinical services. And again, you have to understand sort of the treatments that are covered within your state, particularly in Maryland, that youth can consent for without parental consent. But one technique you can use for IRBs is to define what minimal risk is for an adolescent. So minimal risk is defined as adolescent daily life. It is age specific. It's not the absence, but rather the experiences in daily life. And I think that's key. It's not the absence. And so it's not the absence of harm and discomfort, but what goes on actually. And so you can use when you say, well, when the IRB comes back and says, well, you can't ask these questions. Well, you know, there's some good evidence that this is what we do in clinical practice. So you can use the AAP, the SAM, the ACOG, best practices approaches, information, so that these are screening. You know, if you use Bright Futures, these are screening questions that we use in normal practice. This is regular practice. So this is minimal risk. So, you know, so if, you know, saying that asking about sex, asking about drugs, or asking about something else that's specific to adolescent development is harmful, that's not any more harmful than what we already do in normal practice. Does that make sense? So I think you also have to sort of weigh the potential risks and benefits of sensitive issue research, but there's little data on and little evidence that by asking these questions that it's actually going to increase negative behavior. But there is some data that it actually can potentially benefit youth by participating. For one example is Marriott did a study looking at almost 700 14 to 17-year-old boys. It was a survey just about sexual behavior and attitudes. And predominantly they enjoyed participating. Distress was associated with younger age and not talking to parents, not surprising. But a lot of the youth, when qualitatively asked why they participated, they said that they first thought they would do it for the gift cards, but then that it felt like a good way to talk about stuff, because they really don't get a chance to talk about it in other places. Now, this was a heterosexual sample, but similarly, when you do work with sexual minority youth by including questions about how they feel about that, that's something I'm working on including in my work, then it will also be, it can be helpful to use to inform IRBs to say that there's benefit out of this, and this is what youth describe it. There are also federal regulations that people can cite, particularly 45 CFR 46 subpart D, that provide adequate provisions when soliciting assent, adolescent consent, and waiver of parental consent, as well as the SAM guidelines, which I've sort of cited throughout the earlier section. But the 46 subpart D says parental permission can be waived in which adult written informed consent would be waived. Minimal risk will not adversely affect the rights and welfare of the adolescent, could not practically be carried out without it, and if appropriate, adolescents will be provided with additional pertinent information after participation. And then, of course, not FDA regulated. So this is tricky because with IND studies like pre-exposure prophylaxis studies, we cannot get a waiver of parental consent. It has to be adolescent consent, period. The adolescent has to consent. So any IND study, the adolescent consents by themselves. So I'm going to just move to some effective strategies that we've used. I was telling Holly earlier, I look at her paper all the time. I think it's good to attend IRB meetings, and because there's been some work that demonstrates if you attend, your IRB approval process will go quicker and be much easier. You can anticipate questions that occur or come up in the IRB and try to answer those questions around consent, around level of risk. And then you can also volunteer to serve on an IRB or spend time with an IRB. I think it's important to engage parents if necessary, because sometimes if you can't find youth, then maybe having parents, parental groups like PFLAG, for example, that are your advocates can be helpful in trying to get that move forward. And then also engage in the community around why this work is important. But I think more importantly, learning from others' experiences. I think there's a nice system here for IRB assistance and support. And you can always ask for assistance and feedback before you submit it or if you have questions. More importantly, I think you have to know your local law. So this is, I know it's a busy slide, it's from the Guttmacher Institute. It's what in each state minors can consent to. And so, you know, having information like this to be able to cite to your IRB is very helpful, because then it may also already raise or answer some questions that they are concerned about. So raise awareness to those questions that they may have. So I'm finished. I think there's some common challenges that we face when working with youth, especially sexual minority youth. I gave you one snapshot, a big snapshot of what I've been doing, and where I feel that there's an additional need. There are some IRB challenges that exist and that are real, but I think addressing them head on and trying to be prepared in a thoughtful way, then I think you can actually move forward in this particular area. I'll stop there.
Great. So please join me in thanking.
I'll take questions.
Yeah, we have a little more than 15 minutes for questions. I'll sort of help referee or pick people out.
Okay, all right.
So, yep, back there.
Yeah, so I'm curious about the older partners.
Yeah.
Do you have any idea where these young men are meeting these older partners? And as a researcher or practitioner, you hear that 14, 15-year-old kids are having sexual relationships with 25-year-old adults. What are do you have to report that? Like, what are the implications for those types of relationships?
Yeah, so thanks for asking. Excuse me. Can you grab my water? A lot of youth described, excuse me. Oh, my. Meeting older partners online because, so it's interesting because there were a few youth that described meeting older partners on the chat lines. The chat lines, I think, are falling out of favor because of the newer apps that are available, like Grindr and Jacked. But they talked about going on chat lines because they could actually hear the person's voice. They felt more familiar, and then they could actually meet up because it was instantaneous. But a lot of them described meeting partners, the older partners, online on different websites, either sexual websites or non-sexual websites. Some actually met older men just in their communities, like at bars or clubs, neighborhoods, parks, events, and stuff like that. So I don't think it's all online, but I think it's a wide mix of what's going on with youth in general. It's just a reflection of that. So to answer your second question, so I am a mandated reporter. But I'm a mandated reporter, and all providers in Maryland are mandated reporters. If they're social workers, if they're outreach, clinicians, et cetera. But in Maryland, it's pretty specific about what you have to report, that you're mandated to report. And it's sexual abuse in Maryland and not sexual assault. So a 14-year-old with a 25-year-old would be, and it's retrospective, so I'm not seeing him when he's 14, correct? So that would be considered sexual assault if it was not a family member. So if it was family member, guardian, someone who is in the household, that's considered sexual abuse. If it's not, then that's considered sexual assault. and there are different degrees of rape and sexual assault in Maryland, and depending on the different degrees determines your mandated reporting. A 14-year-old, if presented at 14, you would need to call to help. You'd have to help him to report it. If you were presented at 16 and talked about what happened at 14, then you would not need to report it. So there are some, some trickiness, I guess, in there, or some it's not so cut and dry. There's some gray areas. The age of consent in Maryland is 16, but it also depends on the age of the partner. So a 15-year-old with a 17-year-old is not necessarily considered statutory rape. Did I answer your question?
Yeah.
Okay. I'm happy to send you the document if you want to look at it further.
Thank you.
Chris, and then we have here, and then.
Yes.
Hi, Renata. Thanks
Hi, Chris.
so much.
Thanks.
I have a question for you, actually going back to your case, to your
Yeah.
17-year-old. Let's hope that he turned out to have an HIV test and to be uninfected in the perfect world. Might be a good candidate for PrEP.
Mm-hmm.
So are you having those conversations? Is that getting going out? I raise this question because what we're hearing from providers more in the adult medicine space is that the demand is low and there's still a lot of provider concern. But when you look particularly at African American kids at this age in Baltimore, the likelihood of acquisition is just so unacceptably high. You'd think maybe has a role.
Well, from a provider standpoint, I think PrEP can actually have a big role. We have a PrEP study right now for 18 to 22-year-olds, and we're hoping to get another protocol approved for the younger ones. The challenge, I think, with the younger ones, and we're going through the IRB process right now, so we'll see whether or not we have success with that process, because a lot of it's an open label study, but a lot of the concern is that the youth do not have the capacity to understand the risks of the medications and the side effects of the medications. There's concern raised often. We've heard from other sites that's why there's hesitation to sort of move forward with that protocol. But I think from a clinical standpoint, I think that there is a need for PrEP. The challenges from a clinical standpoint are the coverage for PrEP, that we don't have it readily covered in the insurance providers that are available to our youth. And then some of the youth, although with expansion of care and the Affordable Care Act, will have greater access to health insurance. A lot of these youth are still uninsured or underinsured, and so that provides even another barrier to actually access care for PrEP. We've had some youth describe they can get it on the street if necessary. I think Chicago has had a lot of luck with PrEP in their location. I don't know if we've had the same luck here. I do think that there's some potential concerns, I think, in general about in the community as far as that we've talked about in our coalition, this sort of perception that people taking PrEP may not actually engage in other health protective behaviors and the risk for disinhibition. And so I think that is another sort of barrier to PrEP use. But I think there's a need, especially because of the high rates. And what we've seen in the IPREX study and other studies that have demonstrated 60% reduction in risk for HIV. So.
Thank you so much, Renata. I am as you know, finishing up my PhD in sexuality. So I'm grateful that you're talking about pleasure, because we don't. So that's my first comment. I have a second and a question. The second comment being, we don't talk to adolescents about pleasure. We don't do it. It just doesn't exist. There are no models, right? And so then to be a sexual minority, you're now doubly not having a model about
Right.
what is sexual pleasure supposed
Right.
to be about. Because I feel like we miss, I think as adults, that young people become adults. So what they don't learn, they don't learn.
Right.
Right? And so we wonder how come the adults are doing this because they were doing this as children
Right.
and no one corrected that.
Yeah.
So I'm curious if in your previous study, in the qualitative part, were there any conversations by the young men about, we just kind of go as it grows. We didn't know what to do. We didn't know who to talk to. We had sex because we thought this is what was supposed to happen. There just was no roadmap for us to follow. Did anybody speak to any of that?
Well, it's interesting because I'm in the process of recruiting to a small cohort of young men and people that are, where we're actually trying to find these young men and follow them prospectively and really try to clarify that, because I think we didn't actually get into the detail that I think is necessary to answer your question. What I would say is that youth described just sort of it happening, so it just sort of happened, whether it was in someone's house or someplace else. It sort of happened, that it wasn't necessarily planned in a sense for the most of the youth. There were some youth that consciously said, they were tired of being virgins. They were, feeling pressure from friends. The other adolescent-specific social development issues that contribute to sexual activity before you might be ready or contribute to when you have sex, that did come up. But I don't think we've gotten down to the granular details that you're asking. So hold that question. And hopefully we will, because I think that that's an important question, especially about pleasure and sort of the roadmap for these early experiences. Like, was it planned and how did it relate to who you are today?
When we think about heterosexual couples, socially we teach young girls it's going to hurt the first time. But as you can get past that, you're fine, right?
Right.
And so, but what do we tell then our young heterosexuals?
Yeah, and
what is that?
right, and youth that actually had family members that were also gay, they actually had more pleasurable experiences because they were more aware. Now that's a small sample, so I don't want to make generalizations, but they were sort of aware of what happened and sort of what to expect. Whereas I think it's really also complicated because a lot of these youth don't have people to talk to, so they don't know what to expect, but they also go through the feeling or the experience, and they have all these this other baggage that's contributing to whether or not they enjoy it or not, and so it's complicated. Try to get there.
Two questions. One is in your qualitative work with youth and talking to young folks who are having relationships with older, what they consider to be older men. Was there a dynamic that the condom use was dictated more by the older person who seemed to be more experienced?
Yes.
Kind of ceded their own kind of power about making those decisions to the other person?
Yeah, we commonly heard that the more experienced partner, which was typically the older partner, sort of dictated what happened during that first experience. That he said, I should do this. You could insert it. I don't want to be graphic, I can, but, explicit, but, and that I was doing it wrong. And that there wasn't, a lot of these youth didn't describe checking to see if condoms were used, or trying to actively engage around that because they're younger. If they had it and the other partner was interested, but I think, what I didn't talk about was the youth that had their first experience at a younger age. were a little bit different than the youth that had experience at an older age, because the older adolescents were able to negotiate sexual position much more than the younger youth, whether it was more versatile versus just being a receptive partner.
Second question is, when you're asking teens about their relationships and about, healthy relationships, is that how you asked it? And of those relationships, how many were healthy? I mean, is that?
Yeah, it's funny because
Is there a better way to ask that, or?
it's interesting because I also ask about whether or not they enjoyed sex. Does it feel good? Because I think just sort of asking not only about their relationship and how they see whether or not it's healthy, but whether or not it feels good is a different way of getting at that question, because you hear a lot of no or yes or it feels okay or it feels great. I mean, you get like a very wide variety of answers, and then you can sort of get into, tell me about why it feels good, because then it gets into, well, he takes care of me, or he holds me, or these other things that are important to the youth and stuff. So
we have time for maybe one more.
Some of your talk and some of the questions have made me sort of think of this, and I was wondering if sort of intergenerational mentorship and sort of kinship has come up at all, or if you think that's sort of a possible, is that a feasible sort of community level capacity building intervention? And I'm asking that because if you think about heterosexual youth, granted there's lots of misinformation about sex, but family or sort of adult models are often a source of information.
right.
Queer kids might not have that sort of family support information, whatever. And I'm also thinking about, the sort of massive bereavement, particularly among, gay men and MSM. So there's sort of this broken lineage of tradition and history and culture. And I'm just, what do you think about that? Sort of intergenerational mentorship, kinship.
Yeah. So I think there still exists a lot of intergenerational kinship and mentorship. I think that for some youth, it's interrelated to who their sexual partner is. For some youth, it's not. And I think the question becomes, what is different about those youth that have the sort of the what we would traditionally say was, the house, for example, or the house mother and the father, and it's just the mentoring and the cultivation of who they are, versus there's some interrelated sex that occurs there. Because, we heard from the youth where there were examples that came out where youth had that mentoring relationship that then turned right into something sexual. And so the question is, what's different about these groups where it continues to just be a mentoring relationship that's positive and needed for youth development, versus these youth where it's interrelated to risk within sex with an older partner. And usually those relationships were very age discordant. So, it was the, 45-year-old gentleman with, the 15-year-old young man that was often very displaced from his home because he didn't have that support. And so he sought it in the community. And I think that's still the question that needs to be answered. Because I think if you can find that, if we say we're going to do a cookbook, if we can find what are those factors, those, those components of that recipe, then, we could model that for youth to have healthy mentoring relationships.
Great.
So.
That's a nice place to stop. Let's thank
Thanks.